Thank you very much indeed. Well, it's an absolute pleasure to be here at this overdiagnosis conference, and I understand from the nosology that you're developing for overdiagnosis yesterday that this talk really fits in the over-detection and over-treatment category. It's not about pre-disease, but it's about people who are in a pre-death state and may be adversely affected by over-detection and over-treatment. So, first of all, my competing interests. I am eternally grateful to the governmental and charity bodies that have funded my research, and I've received no funding from the pharmaceutical industry and have no intention of doing so in the future. I'm a firm believer in a state-funded healthcare system, which we still do have in Scotland, and but not for long. And I'm also a subscriber to Private Eye, which means I like scurrilous gossip and knowing the truth about what's really going on in the world. But having said all of that, I'm going to give you my perspective on overdiagnosis in the brain. But my wife is an acupuncturist, so I'm not entirely unsusceptible to quackery and other forms of practice that aren't based on much evidence. So yes, as Carl kindly said, I am a neurologist, and nowadays, unlike Jean-Martin Charcot, who you see up there famously in the Salpêtrière illustrating a case of hysteria, neurologists these days are really not particularly different. And here you see, as many of you will know, Jean-Martin Warlow, our recently retired professor of neurology. And the only difference really between us and Charcot is that we're still interested in the same diseases, functional diseases, which are incredibly common, but now we're worried about the adverse effects of technology that we feel obliged to use when investigating people like this in everyday practice. And that's really what this talk is going to be about. So what do I mean by an incidentaloma in the brain? And as many of you will know, MRI technology is increasingly used and increasingly advancing and becoming higher and higher resolution, so that really almost no brain is normal when we image it nowadays. The incidentalomas that I'm talking about are things like aneurysms, which you see on the left-hand side of the picture there, meningiomas in the middle, or an arachnoid cyst, there. These are things that might have prognostic significance for an individual affected and do have some kind of treatment that one could or could not use to try and alter their natural course. And the most feared complication of these things is bleeding into the head, which is what I'm interested in, anything that bleeds in the brain. I'm not talking about biomarkers of disease like these microbleeds. You see a sort of pepper pot brain there. These are, if you like, pre-disease states, which are increasingly being diagnosed, but I'm just going to focus on incidentalomas, diseases that we know about. So I've got about 20 minutes now to try and defuse these brain time bombs that may one day explode in somebody's head and give you all that I know about them. So these are the main settings in which we may identify them. There's the neurological practice, trying to diagnose people. There's monitoring people who have neurological diseases in whom sometimes an aneurysm may develop, especially if they're a smoker, hypertensive, drink too much alcohol. Of course, we use brain MRI a lot in research, and in the process of acquiring these sexy brain images, one has to acquire the more mundane black and white images, which are the detailed ones that may reveal disease. And finally, the scurrilous practice of for-profit screening using brain MRI, which I will come to. And that's really where my interest started. So there I was sitting at the Association of British Neurologists meeting in April 2006 with my morning copy of The Guardian, and I opened the G2 supplement health page and I saw this eye-catching headline. I was terrified that I would die any minute. And this is a quote from Karen Brady, who many of you will know, a very successful, emblematic woman in the business world, married to a professional footballer. And in this article, she describes developing a nut allergy in her 30s. And I'm just quoting exactly what was said in the article. She develops a nut allergy. And this led to health anxiety. And she was worried about what this signified for her health. So she went to a for-profit private health screening company. And they said, what you need is a whole body MRI. And so she had a whole body MRI, and here she tells this story about how she had this routine health check, and it almost certainly saved her life because an aneurysm was identified in her brain. And she describes what it's like going to see a neurologist, unlike me, I hope, in his private consulting rooms, no doubt, following this MRI. She says, and I quote, "I wanted the neurologist to tell me it was straightforward. But when I said to him, 'I'm a mother, I just can't die,' he said, 'God, you've had 2 kids, I'm surprised you survived childbirth.'" I like to think my communication skills are a little bit better than that, but what he's suggesting is that the fact that she has an aneurysm now implies that she must have had it when she had children, and it's amazing that having children did not make it burst. Well, we know from a self-controlled case series study that has been done that women are at no higher risk of bleeding from an aneurysm during childbirth than at other times in their lives. So that's just not evidence-based. So unfortunately, she didn't have a good experience with a neurologist. She subsequently describes going on to see a neurosurgeon and an interventional neuroradiologist and having this aneurysm coiled, waiting on high dependency unit for the complication that she knew might or might not arise from coiling of the aneurysm. It did not happen, and it all ends happily ever after. But of course, she is left with a lifetime of worrying about a recurrent aneurysm and probably a lifetime of checks on how satisfactorily occluded the aneurysm that was treated now is. So it hasn't, although it may have saved her from a brain hemorrhage, possibly, has it changed her life and improved its quality? And this is the company behind this private health screening, or I should say commercial health screening really, practice, Preventicum. Now, the evidence base that what they do is based on implies to me that they probably should stick to premature ejaculation, which is what their name suggests they could helpfully help people with. So this is their Ultimate Plus checkup, which is what Karen Brady has, which involves a whole body MRI and the whole suite of tests that you have while dressed in a white tunic and white slippers, attended to by beautiful people somewhere in Notting Hill, and all that for a bargain, £3,650. 2 days later, in the men's style section of the Times, which I don't read, but a colleague pointed it out to me, was David Baddiel revealing that he'd been to exactly this same company, and he parodies health neurosis in his approach to having these tests, and he revealed that this company had paid him, had paid for this test, and he wrote it up in the papers. This is just disgraceful. It's not based on any evidence, and I'll show you why. And in the States, of course, Bobby Mercer, a very famous Yankees baseballer, he tragically died of a brain tumour, and charities are now doing this. So the road to early detection is a scan in a van. This brain MRI scanner tours the boroughs of New York and now soon to be all over the US, scanning people who are worried they have a brain tumour. So is their detection fortuitous or futile, which is what I'll tackle in the remainder of this talk in any of these contexts? I've told you about health screening, but these incidentalomas may crop up under any circumstances. Well, first of all, how common are they? Let's get a grasp on that. And this is our systematic review and meta-analysis published in the BMJ after appealing the rejection, Fiona. So it's a happy end to that story. And what we did was we looked in about 19,500 people who had MRIs of the brain at the prevalence of certain sorts of incidental finding. And then we took the reciprocal of that prevalence, which is not the number needed to treat, it's the number needed to scan until you find one of these incidental abnormalities. Incidental brain tumours, scan 143 people, so 2 or 3 in here may then have an incidental tumour on their brain MRI. Other incidental findings like the aneurysms that I showed you, you only need to scan 50 people to identify one of those. So when you group all of those together, you find that there's roughly a 2.7% prevalence of incidental brain findings, which if you're a gambler, you will know is a 1 in 37 chance, which is the same number of pockets that a roulette wheel has, a 1 in 37 chance of finding an incidental abnormality on your brain MRI if it's scanned. This analogy breaks down for our American colleagues who have 2 00 pockets in a roulette wheel, so it has 38 pockets. Doesn't quite work, but 1 in 37 in Britain. So here are some of the abnormalities that may be detected. And what I'm going to do, just because I'm a vascular neurologist, I'm going to focus on the ones that I know about and just give you for each of these three conditions an example of what we know about what may happen if these things are left alone and what may happen if they're treated, to really inform us about whether the detection of these abnormalities, their treatment and therefore prevention may be worthwhile. So this is their rough prevalence. Aneurysms, they are actually under-ascertained by a simple brain MRI. In fact, 3% of the population has an aneurysm in their brain, but this is 0.35% because most brain MRIs don't include angiographic sequences to show you the blood vessels, so you relatively under-ascertain them. But I'll talk about these three different abnormalities. And let's just quickly look at what their burden is in the population. Well, 3% of the population of the UK has an aneurysm. That's over 2 million people. About 102,000 people have a cerebral cavernous malformation, a similar sort of thing, but with a less serious type of bleed. That's just about a Wembley stadium full of people in the UK. And about 32,000 people may have this tangle of blood vessels and arteriovenous malformation. But let's look at the number of those people who come to medical attention from population-based studies that we've done with brain hemorrhage. And that's an incredibly small proportion of the people who are out there at any one time. So the incident presentations are a pretty small proportion of the prevalent pool, which implies that many people may live with these things and never experience a problem from them. So the question is, what's worse, the treatment or the disease? So first of all, aneurysms. And I'll just give you a couple of slides on each of this just so that you can get a feel for what we know. Well, we know from an individual patient data meta-analysis, about 8,000 people, that the annual risk per year of one of these aneurysms bleeding is about 1 in 100. And that continues, as far as we know, for the rest of people's lives, although, and this is a common theme for all of these conditions, the average length of time over which people have been followed in these studies is about 5 years. And it's no coincidence that that's more or less similar as the length of time one can get maybe 1 or 2 academic grants to study these things. And that's the harsh reality, that's one of the limits on our knowledge about these things. What about treatment outcome? Well, as you know, people have shifted from neurosurgical clipping to endovascular coiling, platinum coils in these aneurysms. And the risk of dying or being disabled within a month of having coiling is on average 1 in 20, about 4.7%. So that's quite a high upfront risk, and this is a common theme for all three of these conditions and many brain conditions, that when you treat them, you're often taking an upfront hit for a potential long-term gain. And bravely, Jean Raymond in Canada attempted a randomized control trial to answer this question about whether unruptured aneurysms should be treated. A hugely common problem, and there's an enormous amount of treatment going on with very, very expensive devices that are not particularly well regulated. And he managed to recruit 80 patients over 5 years or so to this trial, which folded with no outcome events, and it was reported in Trials. A deep tragedy for clinicians like me who have to deal with these patients, and I think the mistake they made in that trial was send people to the surgeons and the interventional radiologists who do these procedures. If you go to a barber, you'll get a haircut. But where other diseases have succeeded is where neurologists have been in the front line to portray the uncertainty. So that's where the balance lies after 1 year on the top, harm from without treatment versus harm from treatment, and how that stacks up over 5 years. And indeed, the treatment assumption at 5 years makes some oversimplistic assumptions, namely that further treatment is not done, which it often is, and that the complications risk doesn't double or triple. So really the balance is pretty uncertain for aneurysms. What about cavernous malformations, little smaller cluster of blood vessels that has a less severe bleed? Well, from our population-based study in Scotland, we know that the risk of these bleeding is a bit lower. It's about 1/3 of the risk of an aneurysm bleeding in any 1 year, and these bleeds are less severe. But from a systematic review of the outcome of treatment, the risk of death or stroke is about 8% up front if you're going to operate on a cavernous malformation in the top half of the brain. But if you're down in the clockwork, the brainstem that joins the hemispheres to the spinal cord, you've got a very high risk of suffering death or stroke from operating on the ones in the brainstem. And of course, as is usual in medicine, the ones that are highest risk to treat are the ones that are highest risk if you leave them alone. The brainstem cavernomas are the ones that are more likely to bleed again. And there are absolutely no randomized control trials. although based on our non-randomised findings in our Scottish population-based cohort, you can see that just what you expect and what you see in some other randomised control trials is that outcome after surgery early is poor, and that over 5 years, conservative management, in other words, just doing nothing, and managing these patients' seizures, if necessary, is superior. But that's not non-randomised, so I'm hoping that we can do a trial in this condition. And that's what the risks look like, and the question is really whether the patients will be able to accept randomisation in a trial and whether there'll be uncertainty in their minds, but we shall see. And finally, arteriovenous malformations of the brain, tangles of blood vessels. Again, from an individual patient data meta-analysis, we know their risk of bleeding is roughly the same as aneurysms. All these things are roughly 0.5% to 1% per year, these various conditions, bleeding. And when it comes to treatment outcome, once again, we've got a high upfront risk of death or stroke from treatment, about 7% across all the different types of treatment that may be used to treat these tangles. Neurosurgery, gluing of the blood vessels, or focused radiation treatment. It's often used in combination, so the complications of these treatments are additive. And this year, we did complete a randomised control trial, which was published in The Lancet on the left, which showed a 3-fold increase in the risk of stroke or death after treating arteriovenous malformations. And on the right is our Scottish population-based study, non-randomised, but following people up to much longer, 12 years, showing a consistent difference between conservative management groups and intervention groups in this poor outcome after treatment. So this trial was highly controversial, extremely difficult to do. We've been lambasted endlessly in the journals by American neurosurgeons following the publication of this trial, and it's no coincidence, I think, that they're vociferous about this, and we can talk about why offline. That's really how it's stacking up for patients at 1 year and 5 years, comparing no treatment to treatment. So I think across all 3 of these conditions that I've given you a quick example of, the treatment does seem to be worse than the disease in non-randomised and randomised designs where we have them in just one of those 3 conditions. And there's real uncertainty about what may happen to people in the longer term. So that's basically my conclusion about the evidence. So where does that leave us? What should we be doing about these 4 different scenarios in which brain incidentalomas may be found? Well, NICE, for example, in its guidance on headache, where the likelihood if you have migraine of finding an underlying abnormality is extremely low, has correctly recommended that routine brain scanning is not needed. But patients often want a brain scan. They often come to a neurologist for an opinion about their headaches, but they don't really want the opinion. They want a brain scan. They're worried they have a tumour. So it's a challenge for us clinically. It's also a challenge for guidelines to encourage people to implement the evidence. And we know from a randomised control trial that was published in the JNNP that when patients do have a brain scan as a simple solution to their headaches, randomised design, they're a little less anxious after a few months, but by 1 year there's no difference in outcome between the groups or levels of health anxiety. So all it does is give short-term reassurance. We should not be doing brain scans for people with classical headache disorders. We now recently have put together recommendations on how to handle incidental findings in research imaging. So if you're kind enough to volunteer for a brain imaging research project, you should be carefully informed about this 1 in 37 risk of finding an incidental abnormality on the MRI, and you should be free to decide whether you want to know about it, should it be discovered or not. So there's now guidance on that. But I think the real dark spectre in this area are the for-profit commercial health screening companies like Preventicum. But I'm glad to let you know that they've shot themselves in the foot, because here's their preliminary experience with using this whole-body MRI scanning technique in 298 people, I prefer to call them rather than subjects, customers they probably should have called them. And in the conclusion of their paper, they say, the presented data point toward an increased use of MRI for screening in the future, too right, but to date, screening MRI should not be performed outside a research setting because the cost-benefit relation is unclear. Fantastic, that's something to quote back to them, because at the moment this practice has no clear benefit as I can see it. So I hope that that's a clear indication. And if I haven't fully defused those brain time bombs for you over 20 minutes, then I'd be delighted for you to try and help me with what to do about how to take the next step with this research. We clearly need to do more randomized control trials of interventions, but we need to find out what the long-term balance of risk and benefit is, as I've shown you. We need to prevent detection of these things until such a time as we know it's a good idea. And I'm very interested in ways of involving patients in sharing decisions with us, taking in an informed choice approach to whether or not they want to be treated. So if you're interested in pursuing any of those questions, please work with us whether we become independent or not. Thank you.
Questions out there?
What we notice in psychiatric practice is almost anyone presenting with a psychotic disorder, serious mental illness is now being referred off for an MRI scan. I was wondering what your view of the utility of that is.
Yes, it's a frequent referral from the mind doctors to the brain doctors and then back again. So we discuss this often. I don't think there's necessarily an indication to do it in everybody. But I think when you have people with atypical features or a suggestion that there may be an epileptic basis to it or some other explanation, I think it's worth doing an MRI. I think that's clinically indicated, but I'm not sure that scanning everybody is worthwhile. Is that what you do?
No, I resist that because we hardly ever find anything particularly useful. And then you find these incidentalomas, whatever you call them, and then no one knows what to do about them, and all you do is create more anxiety.
Well, the last thing somebody with a psychiatric disorder needs is...
Carsten Jorgensen from the Nordic Cochrane Center. So you've been bashing the private clinics for offering these health checks for without an evidence base. But really, the NHS health check program is offering health checks in direct conflict with the existing evidence, which rather unequivocally tells us that it does no good and probably does a lot of harm. So public health authorities use a lot of resources to promote health checks for people that we know doesn't work. And perhaps those resources would be better spent banning the private clinics and enforcing those bans.
Yeah. Yes, I'd agree with you. I think it's important that we, one bit is terminology here. We're very interested in terminology in this conference. I think we have to stop calling this private medicine. Private is the wrong adjective. It has an allure to it of privacy. Sure, that's what all doctors offer their patients. This is commercial medicine. That's what we're talking about. It's commercial, and we should call it such. So I think I agree with you that they shouldn't be doing it. And yes, every time the NHS tweets about its health checkup programs and says, hey, are you between 50 and 64, you should go and have a health check, I tweet back to them just reminding them of the Cochrane review that I think your group's done, saying there's no evidence, but it meets deaf ears. Yes, I think it's to be debated, and all we can do academically is keep putting the point across that there's no obvious benefit. I agree with you.
Gentleman behind.
William House, retired GP and primary care researcher. You've mentioned several times the need, well, obviously what we need is more randomized controlled trials. And I wonder whether an alternative to that is to step back and take a moral, ethical and sustainability line and persuade people on that basis. Having had a little space between my clinical practice and my present position, a lot of the things we're trying to use research to prove are bonkers are obviously bonkers without doing the research. Why do we need to do expensive and very difficult randomized controlled trials to prove something that's obvious?
When you see how these treatments are actually used in the world, the evidence does need to be put in place, even if it might show what you believe to be obvious, in order to put a stop to practices that shouldn't carry on. The volume of intervention that happens for aneurysms and arteriovenous malformations without being based on evidence, and the amount of healthcare resource that consumes is huge. If we did care trials, embedded randomized controlled trials in the process of our everyday practice, we'd sew up these clinical questions within a few months and we'd move on and be much more effective. So I think trials are the answer with respect, but I think they're too difficult to do under their current construct, and if we embed them in practice, we'll sort this out quickly and we can move on.
One more just in the middle here. There's about 5 or 6 seats down if people want to come down. Just there in the middle.
Andy, I'm a GP with special interest in headache and one sort of thing. My nearest neurology department is in Hull, and one of the neurologists there, in conversation with me, admitted that he ordered far fewer MRI scans when he did clinics out of the hospital, because he see patients had a different expectation and there was different dynamic to the consultation. So should all clinics take place outside the hospital?
I think they should just simply take place as far away from a scanner as you can get. Yeah. No.
Last one, just last one here. Cheers.
Hello, I'm Rustam Al Shahi. I'm a health psychologist in the University of Sydney. Thank you, that was a really nice presentation. What's interesting about the patients you're talking about is that they've got symptoms and often with a problem, where a lot of what we've been talking about earlier is about asymptomatic patients. So I was wondering, if we're not offering patients, we don't want people to discourage them from an MRI. Is there anything else we can offer them? Because patients often feel they want something rather than nothing. And often it seems when we're talking about overdiagnosis and overtreatment, the difference is something versus nothing, and patients feel, I don't want nothing. So can we find a substitute? And the other question was, we talked about shared decision making, and often that's seen as the panacea, and perhaps we ought to think, maybe we ought to decide, actually we should be shared decision making, we need to make a policy decision that this is appropriate to patients to make their decision when they're in a very distressed, difficult situation.
Yes. Thanks, Kirsten. No, there are many patients who don't have any symptoms who have these detected, but yes, in mainstream clinical practice, patients will often come to us with headache and have these things detected. I think what they need is they need to be listened to. They need somebody who cares about them to talk to them, and they need to listen to why it is they're motivated to have a scan and what they're worried about. And then they need relief of their symptoms. They need effective treatment. Huge numbers of people with migraine who are managed by GPs, often very well, but there are insufficient neurological services to really prevent the amount of migraine that is going on, making people lose work. So I think they need good care. And David will be the first to say that the NICE guidelines contain lots of interventions that can improve their symptoms. So we should just be doing better to manage their symptoms, which are what the real problem is.